Airway assessment and patient positioning. Firstly, airway assessment. Our initial assessment of any patient should be the presence of a patent airway and the patient's ability to maintain that airway. So the assessment will begin with an external look at the patient's airway. We look for any swelling of the neck or face, any obvious facial fractures, any carbaceous material around the nose or the mouth that could indicate an airway burn. Next, we move on to an anterior look of the mouth. We're looking for any broken or missing teeth, any swelling of the tongue, any secretions, vomitus or blood in the mouth, and any other possible obstruction that could be going on. If we've indicated that there is the presence for the patient to lose the patency of their airway or the ability to maintain it, we have the option of an OPA or an NPA. The use of these two airways will allow us to bag valve mask our patient. We do have to consider there is some difficulties with this manoeuvre. The pneumonic boots or the pneumonic moans, as well as a number of others, can be recalled with the difficulties of this manoeuvre. Boots stands for beard or facial hair, preventing a good mask seal, obesity or older age of greater than 55, toothlessness or dentures, and a stiff neck or history of stridor. If we've established that the OPA or the NPA is effective, but we want to get a more secure airway, we have the option of an LMA or iGel. Being a supraglottic airway, there is a number of issues we have with being able to effectively ventilate this patient. The pneumonic rods can be removed. The pneumonic rods can be used to effectively establish whether we're going to have any difficulties with the LMA ventilation. R stands for reduced mouth opening, meaning a smaller area for movement of the airway. Obstruction at or below the glottis level means the effectiveness of the LMA becomes obsolete. A distorted airway or a stiff neck or lungs, which means lung compliance is going to be ineffective. If we've established that any of these airways are not going to be as effective as we need to ventilate this patient, we have an option of an ET tube. For this, we have a number of assessments we need to make. The pneumonic lemon can help us to recall these. When assessing for the need for an ET tube, we have the lemon mnemonic we can remember. L stands for look. As we've assessed with every patient an exterior and interior look of the airway, we have this crossed off. E stands for evaluation. We have the 3-3-2 method. This stands for 3 fingers should be able to fit from the tip of the incisor teeth on the top to the incisor teeth on the bottom. 3 fingers should be able to fit from the chin to the hyoid bone, and 2 fingers should go from the floor of the mouth to the thyroid notch. We move on to the Mallampati classification system. Class 1 or Class 2 of the Mallampati means we have a good airway and we're going to be able to intubate. Class 1 of the Mallampati means you're able to see the facial pillars of the mouth, the soft palate, and the uvula. Class 2 is being able to see the facial pillars and the soft palate. The uvula is obstructed by the tongue. Class 3 is only the soft palate is visible, and Class 4 means all of these are obstructed. Once the need for an airway has been established, we need to position the patient to facilitate the placement. The most common position is the sniffing position. Remember to avoid this position if there is suspected or known C-spine injuries. The sniffing position requires flexion of the neck and extension of the head. A cushion placed under the occiput of the extended head improves the angle between the line of vision and the laryngeal axis. Ramping should be considered in obese patients. Alignment of the external anterior meatus and the sternal notch on a horizontal plane should be established. To do this, we use linen, towels or pillows in order to elevate the shoulders and the head. create the horizontal plane between the ear and sternal notch. Caution is required in patients with C-spine injuries, known or suspected, because this will further aggravate any injuries that are going on. Manual inline stabilisation is all that is required.